everyone. We are very pleased to welcome you to this, our sixth Maryland Rural Opioid Technical Assistance Project webinar in 2021. Maryland ROTA is part of a Substance Abuse and Mental Health Services Administration initiative. It is based at the University of Maryland and is conducted in partnership with local and state organizations. Our PI is Dr. Jinhee Kim. My name is Erin Artigiani, ROTA Co-Director. Barbara Kerr, our digital media manager, and I will be the facilitators for this webinar. Maryland ROTA aims to strengthen the capacity of rural communities in Maryland by helping our communities identify, understand, and respond to the evolving drug misuse crisis. Our multidisciplinary approach includes delivering evidence-based training and providing access to current information and local resources through the ROTA website network and webinars such as this. We encourage you to join our growing ROTA network to learn about best practices, access educational opportunities, ask questions of peers and experts, and share your local experiences. More information about Maryland ROTA and a link for joining our network are available at www.marylandrota.org. This webinar explores the impact of social determinants on overdose deaths in urban and rural communities. Today, we are excited to be joined by Dr. Casey Pinto, Assistant Professor at Pennsylvania State University College of Medicine. This webinar will be approximately 60 minutes long, and we encourage you to submit questions and comments during and after the presentations. Please do not raise your hand, however, because we can't call on you during this session. Instead, we ask that you please post your questions in the Q&A box. You can use the chat box as well. We will check both during the webinar and we'll respond to your questions as they come in. We will also hold a Q&A session after the presentation for any remaining questions. We will do our best to get to all of your questions today. A copy of the presenter slides and a recording of this webinar will be made available on our website, which again is marylandrota.org. You can find the webinar page under the Services tab. Thank you, and we hope you enjoy this webinar.
All right. So hi, everyone, and welcome. I'm really excited so many people are here. The title of the presentation is The Impact of Social Determinants on Opioid Overdose Deaths, a Rural-Urban Comparison. I'm Casey Pinto. A little bit about me. I know I was already introduced as an assistant professor at Penn State in the Department of Public Health, but I'm also an infectious disease nurse practitioner who studies sexually transmitted infections, which we see, and the impact of social determinants and rural urban variables. And because of that research, we really started looking into opioid overdose, since opioid use has such an impact on STI rates and acquisition. My co-authors for this paper are Zhen Lei and Zhongyang He, who are both from the College of Mining and Engineering, which you'll see why they joined me for this project in a little bit. And then Dr. Jennifer Moss from the College of Medicine in the Department of Family and Community Medicine, and Guanqing Qi from Rural Sociology. And all of us are from Penn State. And again, if you do ask questions throughout the presentation, I will try my best to answer them, but I'm noting that for some reason it's, oh, there it is. Okay, so if you do have any questions, I'm happy to try to answer them. So a little bit of background. Now, what I didn't mention in that broad overview is that since I'm from Pennsylvania, as well as my colleagues, our research was a pilot study looking at just Pennsylvania. But just because I did that doesn't mean I'm not going to talk about rural-urban disparities overall. So I'll give you some background. We'll talk about that. We'll talk about our study and our findings and what we think they mean. And then, at any point during the time, I'll try my best to answer questions. So first thing, when I initially wrote this paper, this report was not out. This new report from March 2021, and we were still working with 2015 data because it really hadn't been updated for a while, but this new report from the CDC came out. They looked at overdose deaths comparing urban and rural from 99 to 2019. And as you can see, this has been an upward trend. So it doesn't matter rural or urban, overdose deaths are increasing, which we know because it's been hitting the headlines everywhere. What I do expect to continue to see is this fluctuation where rural's higher, then urban's higher consistently. So I would not be surprised if in a couple years rural peaks up above urban. I think that goes hand in hand with the, when urban's higher, we start to direct targeted interventions toward urban sites. When rural's higher, we start to direct interventions toward rural sites because that's where the funding is. So I think that's why you kind of see that spin, but I also think that there's different factors that impact this that we'll talk about. And that's why, the factors we drive towards rural populations, you don't necessarily see the same factors working in urban populations. Even though we know that overall urban is higher, there are 5 states where rural rates are actually higher than urban rates: Vermont, Connecticut, Virginia, North Carolina, and California. Their rural overdose rates are higher than in their urban. And then the dark blue states, I won't list them all, but I will point out Pennsylvania, my home state, and West Virginia, we're seeing higher rates in urban settings of overdose deaths. And then blue, there was no real change. So Maryland, you haven't had a change at all. And then New Jersey and DC do not have any rural counties, so they couldn't do a comparison. But when you break that down and you look at it by the type of drug used, and I'm sorry, this is a little pixelated, but I'll do my best to describe it for you, or if it's too small that you can't see it, I do apologize. But one thing I want to talk about here is the difference in opioids. So synthetic opioids are, and they say other than methadone for this specific one, are tramadol and fentanyl. So urban populations are having the highest increase and have a much higher rate of fentanyl use compared to our rural synthetic opioid population. And that kind of goes hand in hand with what I'm seeing in the hospital. We're seeing a lot of fentanyl, and we've even had some carfentanil overdoses in the hospital system that I work in the urban setting. And we've seen more straight heroin use or other drugs in the rural population. So anecdotally, this is playing out in our region. When you move on to these natural and semi-synthetic opioids, you can see that they're actually higher in rural populations. And that's probably going to go hand in hand with what we talk about in a little bit about the prescription drug monitoring program. And what these semi-synthetic opioids are, those are your oxycodone, your hydrocodone, hydromorphone. I have a little list for myself because I can't remember them all, and oxymorphone. So a lot of those are essentially pill form, or ones that you could be described. And that may be part of the reason why we're seeing it a little bit higher in rural compared to urban. And then the last one is heroin. Heroin is higher in urban populations compared to rural. And again, this all has to do, I believe this all has to do with access. And there's some literature that backs up that access to these drugs are part of the reason why we see that. So age-adjusted rates for overdose deaths for stimulants, even though I know most of us focus kind of on heroin or fentanyl because those tend to be more deadly, it is important to include some of these other ones. And what you notice here is that psychostimulants with abuse potential, the first one that comes to mind here is like Adderall or Ritalin, are much higher in rural populations. And again, that kind of goes hand in hand with access. So it's likely easier for someone to get these prescriptions from their provider than it is to get them on the street. And we'll talk about the PDMP in a little bit, which will may explain some of these. And then otherwise, cocaine, it's higher in urban areas compared to rural. And I keep beleaguering the point about access, but it's likely related to access. And so just a reminder, those last graphs we talked about only went up to 2019. So they did not quite make it to COVID. So I have to kind of talk about that. So 2019 hit, and then to December 2020. So this period where COVID hit, we saw this huge increase of 29.6% for reported overdose deaths. The only states that did not see an increase are New Hampshire and South Dakota. Otherwise, every state in the US saw an increase in overdose deaths during the time of COVID. And I really think that that is a point we have to hammer home. not just because of COVID itself, but because of all the ramifications that happened with COVID. And I can completely beleaguer that, but I'll try to hit on some of the main points. So when COVID hit, we shut everything down. We shut down our clinics. We made it much harder for people to get in. We slowly transitioned to telemedicine. We did the best that we could, but ultimately that led to a decrease in access. So in patients who may have been stable on methadone or Suboxone, their risk of overdose was higher because they started withdrawing and going through pain and had nowhere to go, so they turned to the streets. The other point is, during COVID, since we were all socially isolated, it made it much easier to get depressed. And I think even the best of us who did infectious disease and thought, and I work in public health, and here I am thinking, okay, a shutdown's a good thing. Most people want to work from home. There's evidence that working from home is good. But what we found is that's not necessarily the case, that there have been a lot more mental health issues. And we all know that mental health issues coincide with overdose. So of course, COVID had a major impact on overdose deaths. And I'm going to kind of talk about them at the state level and the national level here. So nationally, this is the data I pulled. I think I pulled it Friday. I'm a prepper. I'm normally last minute, but I've changed to becoming a prepper lately. But in the US in 2015, we had about 50,000 deaths. This kind of went up. 2018 started to level off, and then COVID hit. And you just see this huge spike in the US for overdose deaths related to COVID. And, I already beleaguered all those points as to why we think COVID had an impact. I'm picking on Pennsylvania because that's where I live, but we had about 3,000 deaths a year in 2015. It peaked, and I believe I have an explanation for why. It has to do with the prescription drug monitoring program, which I'll talk about in a little bit and explain this point a little bit better. But then we kind of declined and leveled out. And we leveled out nicely, and then again, COVID hit, and we started to spike again. And we didn't spike as high as I thought we would, but we're still seeing data from 2021. And I have seen a lot of IV drug related infections in the hospital, way more than I had prior to COVID. So I definitely think that this is, data is here, but I think that we'll likely see a little bit more, especially as people struggle to get off. I picked on Maryland because Maryland Rhoda's who's invited me to come and give this talk. So Maryland nicely has much lower deaths than Pennsylvania, so about 1,000 compared to our 3,000 in 2015. But as you can see, it kind of followed the same trend. It went up, kind of hit this nice level peak, and then you thought maybe we're stable, we're making some progress, and all of a sudden COVID hit and we spiked again. So a little bit on the socioeconomic background here, and I'm sure I know I'm speaking to the choir, but I just feel it's so important to talk about this. And there's this great study that was published that will be in the notes portion of the slide that is a nice review of all the socioeconomic and sociodemographic variables that impact opioid use and overdose deaths. The first one is prison. So this one was kind of complicated because just being in prison doesn't increase your risk of overdose death. It's kind of habits that got you into prison, and then what happens when you leave prison. And it depends on the resources you're given. So patients who leave prison have a much higher rate of overdose death. So there are associations between prison release and overdose deaths, and it could be because they were able to be successfully weaned off the drugs, and then they went out and thought they could still use 10 packs of heroin when they weren't used to that. So there's these higher rates of overdose deaths related to that. Do a quick check on questions. Okay. As far as income and poverty, I'm assured that I'm speaking to the choir here, but the lower the income, the higher the rate of poverty, the higher the rate of overdose death. And the question, in my mind, because whenever we say as correlation does not equal causation, which came first? Are people in poverty because there's such a large drug problem, or are people using drugs because there's like they have this bleak outlook on life because they're living in poverty. That's all that they're exposed to. So there's all these different relationships here that you can start to think about and question which came first, the chicken or the egg. Unemployment, so this one's possible across the board. So the studies kind of varied. Some studies showed in areas with high unemployment, there were also high rates of overdose in areas, but other studies showed that this was not true. So it's kind of one of those that are up in the air. And again, I make the same argument. Are these patients unemployed because they have a drug habit that they can't kick, or did they start using drugs because they were despondent from being unemployed? Yes, you will be given a downloadable copy of the presentation. And Medicaid enrollment rates. So most of the studies you see are really a marker for poverty. So when someone's enrolled in Medicaid, they typically have to live at some percentage of the poverty level to be eligible for enrollment. So most of the research that used Medicaid, it was used as a marker for poverty. So again, the higher the rates of Medicaid enrollment, the higher the rates of overdose deaths, very similar to the poverty question. And the one thing I didn't mention about prison and Medicaid, that for some reason I thought I was going to mention down here, but I want to go back to it, is that patients who are in prison in some states, so in Pennsylvania, if you are in prison and you're enrolled in Medicaid and you go to prison, they suspend the account. So they don't delete it, they don't kick you off the account, they suspend it, and then you use prison medical care. And then when you leave prison, you can get back on that insurance immediately. There's not this big lag. In other states, if a person on Medicaid goes to prison, they lose that insurance entirely. So when they leave prison, they don't have access to that insurance. And then it takes them much longer to get enrolled, because if you've ever helped someone enroll for Medicaid, it can take months. It really can. It's really not a quick process. Unless, of course, you're disabling them for some reason, then it's a little bit quicker. But that being said, these patients may have gotten started on Suboxone while in prison and then just don't have access to these services when they're out because they don't have insurance. So that may be another explanation as to why these rates of prison-related overdoses are higher. And there are actually people studying that exact topic right now and looking at the differences. Did I observe a large increase in overdoses shortly after the stimulus checks were issued? No, I did not. But that's because I'm not looking at all of the data. I'm only getting aggregate data, and I would have to look into that. I'm sorry. And then the second question I just got was, do you have any stats on youth overdose across the country? I don't have it with me in here, but I'm sure that, I focus more on rural urban, and they tend not to split out youth as much. I do talk about it a little bit in my pilot data when we get there, so we can talk about that there. All right. And then education level is the last one. So the higher education level attained, the lower the rate of overdose death, which is pretty solid across all the literature. The higher educated someone is, the less likely they are to overdose. But again, all of these just fit this nice big puzzle, which is why I'm in public health. Because when you have education level, it's harder to get a higher education level if you live in income or if you've been in prison. It's just higher to make it to these next levels, or if you're unemployed or unemployable. So I think that all of these fit in this nice little bubble that kind of explains, and no single one of these explain anything. Anyway. So for those of you who aren't familiar with Pennsylvania, it is my home state. I have lived here my whole life, except for a brief stint when I worked at Hopkins. But these are our new Welcome to Pennsylvania signs, which I did not know they were new until I was trying to find a picture for this. And then this is just to remind people that Pennsylvania is more than Philly and Pittsburgh. And this is the Allegheny National Forest out in northwestern PA, and one of the 3 rivers that converges around Pittsburgh, which I do not know which one, so I apologize. I should have looked it up. And then the college that I work in is located in Hershey, Pennsylvania. So of course I had to put welcome to Hershey because that is where I work. And again, just to remind you, Pennsylvania is more than Philadelphia and Pittsburgh. Philly's down here. Allegheny County houses Pittsburgh, and all the yellow counties are what the Center for Rural PA considers urban. I actually live in York, in this tiny little rural area in York, even though York's not considered rural. I'm sure you guys would argue that Lancaster could be considered rural because of all the Amish. But what's nice about Pennsylvania is we have these nice delineated counties, Allentown, Bethlehem, Allentown, Easton, and then Scranton for those of you Office fans, Erie, Pennsylvania, and then the rest of us were pretty rural. And we even have, like out here, there's a collection of counties. These are frontier designated counties. So they're so rural that it's almost like you're in a frontier region. So Pennsylvania has this nice breadth that you can help understand, but what it is lacking that can't contribute to other is our racial makeup of our rural population is like 98% to 99% white, and that's creeping up with Hispanics. So we've gone from like 1% to 2% Hispanic, but we're really not seeing a large Black population in our rural areas like you would see in, say, like Alabama, North Carolina, Mississippi, where they have a much larger proportion of Black in the rural areas. We're more Appalachian rural. So this other thing I just want to touch on, and I told you my mining and engineering friends would come in handy, but this is kind of one of the things we're thinking as a possible explanation of some of this data. Some of the findings from our data when we get there is fracking. So if you don't know about fracking, it was the next best thing since sliced bread in about 2008, 2009, and Pennsylvania went crazy with drilling wells. So all these red dots are gas fracking wells. So these are our unconventional wells. So the wells that go down and dig over, which had a huge implications for environmental as well as the social impact of these and what was coming into the region. Since I study STIs, I was looking at STDs that came in on people to the region and then spread rampantly, which was documented well. And then the blue wells are all our oil wells that are conventionally dug. So they just go straight down into the ground. Less concerned, still concerning, but less concerning than these unconventional wells since we don't know about them. But the big aspect with this is that this should have brought money to the region. And it did, but how did it impact other things? They didn't really bring a lot of jobs. They said they would, but they brought all out-of-staters to the region to work on these rigs because you don't want to hire and train someone when you already have people who are hired and trained and can just go up and drill these rigs, and then they leave and there's really little oversight. So it brought money, but didn't necessarily bring jobs. And then the next thing I want to talk about is coal mining, because up until like 10 to 15 years ago, in these pink areas, especially in this region here, there was a huge amount of people whose entire town depended on the coal mine to survive. And we've seen this before. There's a little region over here where I'm from, over here, called Bangor, Pennsylvania. And that is like Bangor, it's like called the slate belt. So we were big slate miners. And what happened was when people didn't use slate as much, the town just kind of poverty hit, there was no jobs. People got despondent, mental health, all those pieces that come together. And we're starting to see that play out again in some of these coal mining regions as coal is going the way of fracking. And they really thought fracking would make a difference. But because they don't need as many people to mine for gas and oil as they do for coal, it's still leaving a lot of people out of work. And these are backbreaking laborers in the coal mine. So this is definitely blue collar, hard work. So I just had to give you a little background on PA. And then I said I'd come and talk about the Pennsylvania Prescription Drug Monitoring Program. So this is a bonus for us. This was implemented in 2016, and I have a question. So the person asked Monique if the coal mining and fracking regions seem to be located in more of the frontier rural regions. Did this make a difference in the opioid rates in that area? because the population is so low in those regions, we can't actually look at the data and see any predictable trend over time. The cases are just too low and the data just gets so skewed that it doesn't give us a good answer. It's difficult to even trend because there's so few cases and it varies from year to year. So it was hard to kind of pull data from those specific regions or counties. But we will talk about the whole rural piece as a whole, which seems to encompass almost all of that area. Okay, so back to the prescription drug monitoring program. So in August 2016, this was implemented. Every provider, every prescriber had to have access to this, including pharmacies. So we had to have access to this and check it and document that we checked it before we prescribed any opioid drugs. And this helped us kind of see who was really abusing the system versus who wasn't. So from 2017 to 2019, there was a 33% decrease in the quantity of opioid pills prescribed. This is huge. So we're really prescribing less. And a lot of this is among, and I don't want to pick on anyone in particular, but those who see people emergently. So people who operate, see them kind of once, give them enough of a prescription, they won't come back. Oral surgeons, people who break a leg. So they're in the ER, they break a leg, they're given a 30-day supply of opioids instead of, a 3 to 5 day supply, which probably should have been more sufficient. So we're seeing a huge number in those, but we're also seeing an 18% decrease in authorized refills. So these are our patients who get these consistent refills of these prescriptions and they may not need them. And now that we're checking, we're seeing that people are using other pharmacies, other providers, and we were able to cut down on some of the pill mill practicing. And that's why I think it had an impact on Pennsylvania. So about August 2015, it was implemented. We implemented that. So we stopped giving people opioids, so they went elsewhere. So they went to the street, they used heroin, they used something else. Carfentanil was hot at that point in time. And then you start seeing that drop off as we start getting these people help and we start getting them off and we stop over prescribing. So that's why I think we started to see that decline in Pennsylvania, coupled with our Narcan outreach. And then COVID hit, which we talked about ad nauseum. The other cool thing that Pennsylvania did was we really made it a crime. We made it a crime to prescribe opioids for sex. And the second one, this like nice big one in the middle, really just these pill mill schemes where people were giving it out for money. We made it easier to whistleblow. It just made it much easier to get these people, to stop them from doing it. And because of the PDMP with every opioid tracked, it was easier for the Attorney General to say, well, you're giving like 30% more narcs than anyone else, and you're not a pain medicine clinic. Like, what's happening here? So it was much easier. So we had a lot of that. And I think that's also why we saw that decline. The other nice thing we did, and I just pulled this map, is Pennsylvania made centers of excellence for addiction. And, we have our Philadelphia, Scranton, for those of you office lovers, if you want to go hang out in Scranton at an addiction center, there you go. Pittsburgh, Harrisburg, we had several, but then you see spread throughout these rural areas. State College is where Penn State University is. Du Bois, Sayre, which is in the middle of nothing if you've ever been up there. Wellsboro is the county seat for Tioga County, but also there's nothing surrounding it. Where I do think we're lacking is this region here. But again, the population's so sparse that they're actually used to driving. So it takes about 45 minutes to an hour to get from Wellsboro to Coudersport, and then another 45 minutes to get to here. So really an addiction treatment center is with probably an hour and a half of anywhere in the state. I do think we also need something down in here because, being in central PA, we just have such a huge problem between Carlisle, Chambersburg, and Gettysburg and addiction. I see a lot of them at the Carlisle Hospital and the York Hospital. So there really is a large addiction thing. But in the meantime, the other thing we push that I don't have a slide on is Narcan. So we have been giving Narcan out like it's candy to patients, to providers, to family members of people who use drugs, to police, EMS. So all of our state troopers have Narcan on board. We tried to get it out to as many little barracks as we can. So that's also another reason why our overdose deaths have declined, because especially in these rural areas, if they come across someone unresponsive, they can give them Narcan to start while they're trying to figure out what else might be going on. And it's a good, quick way to kind of get them moving. You know, before COVID, I saw an overdose on a train in the bathroom, and my friend Kelly and I were like, anybody got Narcan? No one? But luckily, one of the Amtrak, I actually don't know what they're called, but they actually were carrying it and were able to get it and were able to administer Narcan and get them off at the next stop. So it is useful, and I've seen it in action when I was just hanging out, being a normal human. All right, so back to my study. So what we did was this nice pilot data. We used 2003 to 2017 data. The data we used is the US Census Bureau and the CDC mortality microdata. Unfortunately, we could only analyze at the county level because we're limited by what the CDC gave us, whereas the Census Bureau would have allowed us to go a little bit smaller. And I could talk for hours about why rural designation is important at kind of the local level, not the county level, but I'm limited, and I'm sure you guys can agree with me. I mean, I grew up in a county that's designated as urban, but there were more cows and tractors than people, and I grew up milking cows. So I would count myself as growing up in a rural area, even though I'm designated in an urban setting. Anyway, the analysis was a fixed effects linear regression model, and we controlled for time in varying unobserved county characteristics. So essentially what that means is, because we had to use county data, and because some of the numbers in some of these rural counties were so tiny, we use this time in varying to make sure that if something changed in that county, we could kind of control for those possible outlying things that we didn't include in the study because we either didn't have access to the data, or we didn't have access to, or we couldn't include it because it would have skewed the model too much. So it kind of helped control for some of those outlying characteristics and made the model much more stable. So here's our data, and I'm going to break this down piece by piece. So first, we're going to talk about unemployment rate. So the higher the unemployment rate in urban settings, the higher the rate of overdose death. 2 stars means a p-level of less than 0.5. 1 star means a p-value of less than 0.1. And the reason we use 0.1 is because the data was so small. And I know everyone always says 0.05, but this still tells me I'm 90% correct, essentially. Like, there's only a 10% chance that my answer is wrong, so I'm still doing pretty good. It's really hard presenting when I can't see people's faces. So I hope you're out there amused a little bit at me. Otherwise, I'm just going to ramble on forever. Anyway, so we weren't surprised by this because we know from the history that this is an association that's normal. And then when we look at rural, it's actually the opposite direction. Now, granted, nothing here is significant. So these numbers could be wrong. They're pretty close to 0. It's very possible. But all 3 were lower, which was kind of a surprising finding and definitely warrants some more research, because maybe unemployment rate doesn't play such a big role in rural Pennsylvania as it does in urban Pennsylvania. So next was poverty rate. This was surprising for us because typically the higher the poverty rate, the higher the rate of overdose deaths. But in the urban setting, this really didn't play out, because the higher the rate of poverty, the lower the rate of overdose deaths. So we kind of pondered why this may be, and it may be just because over that time period, there had been a lot more interventions into the urban population. So those in the most poverty-stricken area may have had more access to overdose treatment or substance use treatment, but we don't really know. And again, it's kind of some food for thought, pilot studies, so some future research. Rural, again, it didn't play out. So the higher the poverty rate, the higher the rate of overdose deaths. So this is what we would have expected to happen. Thank you, Anonymous, for agreeing that 0.1 is perfectly valid. as a p-value. Yes, I agree. All right, so per capita GDP. So this overall is the gross domestic product per capita. And what we saw was the higher the per capita GDP, the higher the rate of overdose death. So this again does not correspond with our poverty rate thing, because the higher the poverty rate, the higher the rate of overdose death. So one would think that if the GDP is high, or the overall income for that county is high, that this would be lower. But across the board in urban and rural, this is not the case. And we thought that perhaps in our rural populations that this is related to fracking, because when fracking came in and increased that county GDP, and we're really exporting this wonderful product. We have jobs, but only a few. And it may be that kind of skewed the data, because we really did see a lot of income and GDP come out of these rural counties from mining and fracking. But over time, the jobs got less. I have a couple more questions. Let me see what we have. So one of these questions from Carrie is, do you think that the rural rates may be underrepresented because of stigma, lack of resources, or just isolation? I really have to say that that's very possible. But because we're looking at overdose deaths, I think that that's less likely. So substance use, yes, but overdose deaths, because they have to go to a coroner, they have certain tests they have to run. I would expect that these numbers would be fairly accurate. But I'm not sure. And then the lack of resources and isolation, I definitely think lack of access to resources for overdose deaths is definitely a big factor here. And then, so the higher the poverty rate, so the next question from David, he just asked me to clarify poverty rate. So the higher the poverty rate for urban, the lower the rate of overdose. That's what those negatives are. But when you switch to rural, it's the higher the rate of poverty, the higher the rate of overdose deaths, which is what we expected based on preliminary research and other data. Even though these are not significant, they are more in line with what we expected compared to these significant values from the urban side. And then the next question, in rural, yes. Sorry, David, I missed that. So yes, in rural it was, but it's not significant. And the year the data was based, it's 2003 to 2017, because again, so few cases, we needed enough numbers to stabilize the model, and we did look at it over time. So we did look at county level indicators we couldn't look at it by zip code or census tract. We had to look at it by county, because that's the only way we had the county data or the death data. We unfortunately couldn't look into it at zip code or census tract to run this analysis, but that's a great question. Actually, all these are great questions, so I apologize if I don't tell you your question's great. There's another comment here, but I may save it for after from Monique. So thank you. I'm just trying to be cognizant of the time. So per capita GDP, I talked about why that might be. Population density. So the more dense an area is, the lower the rate of overdose. And that plays out across, and this ties in with every literature you can find on access to care. So if you have a higher population density in an area, you're more likely to be close to hospital services, or it won't take nearly as long for an ambulance to get to your house. One of my students did a great analysis on this in Chester County, where he looked at time it takes from 911 call to when the ambulance arrives. And obviously those in a higher population density setting had a much shorter time for when an ambulance got there than those in a lower population density. Even when you have those volunteer companies that are working out there, most of the time those volunteers are not on site. They have to drive from their home to the ambulance, then to your home. I know my uncle cardiac arrested in his house a couple years ago, and we had to call the ambulance. And like I said, growing up, he lived on the farm. It took them 27 minutes to get there from when we called. So obviously time is an issue. If he lived in a city, it probably would have taken 5 to 10 minutes. And, it's just the difference in the timing. All right, now these I just included because we did do an age analysis, but the way the analysis is done is the higher the percentage of the population that's aged 15 to 44, the higher the rate of overdose. And that's overall male, female across the board. In urban, it didn't play out as well in rural. 45 to 64, the higher the rate of the population aged 45 to 64, the higher the rate of overdose. And over 65, these we kind of just looked at for demographics because they don't really tell us anything until you get to rural. So there's this one little piece in rural where the higher the population over 65 among women, the lower the rate of overdose death. And we think this is directly related to the use of these semi-synthetic opioids. So your oxycodones, your Percocets, in the male population in these rural regions because they had such demanding jobs, and they had overall, they were, these blue collar jobs made them more, they had more aches, they had more pains, they had more breaks, they had more falls, they had more pain related causes and were more likely to be prescribed these, and potentially could have increased the overdose death among men, which is why when it's higher women, you don't see that same number. But again, this all has to be further researched. These are all kinds of just us trying to think through why some of these findings might be. Who checks the accuracy of the medical examiner's findings in light of Baltimore City's medical examiner who let racism control his findings? This is a great question that I don't have the answer to. And I know a lot has come up with this in COVID, so I really wish I had an answer, but I know very little about coroner's job and that, but I do know that you don't need as much education as I expected. I know we have several coroners that are nurses who went to coroner training school. So it's really hard for me to say. I apologize that I don't have that answer. All right, so moving on. So this is really just kind of preliminary findings, really early insights into what we thought might be rural urban differences in this opioid overdose deaths, at least in Pennsylvania. Our big kind of takeaway is Narcan accessibility is likely making a difference for rural PA because they don't have to wait as long to get to a hospital to get Narcan administered. Gender differences, we did talk about blue collar jobs, and of course the impact of COVID. So I expect that those overdose deaths are not going to correct quickly because we've had a lot of people without access to their typical pain management who may have turned to the streets. And I suspect we'll see more opioid overdose deaths just based on the sheer volume of IV drug abuse patients I'm seeing in the hospital who have infections. Like it just, I really think we're going to see more, and I don't know when it will peak. I can't predict that, but I do think that we should all be on alert. And then here's my information. You can email me. These slides will be available. And in the notes section of the slides has links to the articles that I cited. Sorry, I didn't put them on the slide. I meant to and then completely forgot before today. So I'm going to stop sharing now and try to answer as many questions as I can.
Thank you so much, Dr. Pinto, for a great presentation. That was really a thorough review of your research and all of the other information that you presented as well. Thanks for including some information about Maryland trends for us today. And just a reminder to all our participants, I know a lot of you have been sharing your questions and comments along the way, but for the rest of you, please remember to drop your questions or comments into the Q&A box for us. And I think a couple of you have put your thanks in the chat box as well. So I'm glad that you enjoyed this webinar. And We'll keep things going a little longer to see if any other questions come in, but I'll also encourage you to join us online on our virtual communities. We have the Maryland Rhoda Network, and we also have the Caesar Research Network, which is hosted by the Center for Substance Abuse Research here at the University of Maryland. And the Caesar Research Network has almost 2,000 members now from around the United States and many other countries as well, including practitioners, policymakers, people with lived experience, and so on. So it's a great resource for asking questions and sharing information and continuing discussions like this one about stigma and social determinants. So I hope we'll see you there. You can join from our websites, either marylandrhoda.org or caesar.umd.edu. Caesar is CESAR.umd.edu. Okay, it looks like there are a couple more questions coming in now, Casey, so I'll let you jump back in again.
Yeah, so Monique had brought up a point before, and I was trying to read her comment and think through during the presentation, and I didn't do a good job. So let me reread her comment, her second comment, and then answer it now. So she said that stigma may impact lack of access to treatment or other healthcare services, particularly in areas where there are limited substance abuse treatment centers or where people may feel fear about being known. And you know what, I agree with you 100%. So I was thinking in the actual like numbers of overdose deaths, not in the causing overdose deaths. So yes, 100% agree with that. Thanks, Glenn, for your comment. And then, have I seen a rise in overdose deaths from polysubstance use? No, I haven't seen the data on that, but anecdotally from being in the hospital, I have seen an increase in IV drug use patients who are using uppers as well as downers. So the methamphetamine and fentanyl definitely come. I'm seeing more of that than I recall seeing before. Some of it may be retrospect bias, but I don't know. So yeah, definitely seeing more. I don't have any hard evidence on that, but I'm sure someone has data on that. So if the associations were different over time. So we really wanted to do this nice time varied experience, but unfortunately, since the numbers were so low, specifically in the rural areas, we had to just control using that time in varying control model to make sure that if those associations were different over time, that it was controlled and we had an overall estimate from that time period. But I agree, we definitely should check if they are different over time. There just wasn't enough data to fit the model, and the model wasn't able to tabulate. Like we weren't able to get any output because the math broke the SAS. A curious point, is there a % of clergy who are actually patients of opioid abuse? Richard, I'm not sure what that question means. I apologize. Do you mean that use opioid abuse? I honestly have no idea. And I know all the rage has been about, has been more related to child abuse. So I haven't paid much attention beyond that, but it's possible that, you know, if they were users, maybe they got clear, got clean, and then became clergy. I'm sorry, I don't know the answer to that. Syringe service programs in rural areas. So in Pennsylvania, our rural areas are incredibly conservative. So Philadelphia does have a syringe exchange program, and I believe Allegheny does, but Harrisburg does not. We talked about implementing one in York City because we have a big problem, but it was kiboshed. I mean, like kiboshed to don't even bring this up again. Like we got the zip the lip, shut the mouth, not again. So our rural areas, if they do have one, it is very, very quiet and hush hush and not something I know of, just because of how conservative our rural regions are. There are, across the board, there are opioid, someone asked if there are opioid issues in Lancaster, and across the board, there are definitely opioid issues. The hospitals that I work at, the hospital system is UPMC Pinnacle. So I cover ID for 7 hospitals, and the one in Lancaster is in Lidditz. So it's kind of outside of the Lancaster bubble. And the majority of those patients go to UPenn, but I would imagine that there are, because when we try to transfer IV drug abuse patients to Valley Forge, which is the only place that will accept patients with a PICC line, we're normally competing with Lancaster and some of those other regions for opioid use. But yeah, York, Harrisburg, it's just underground and you're just not seeing it. And it kind of goes in line with human trafficking, which we're seeing in Lancaster, York, all the way up 11 and 15. If you know, it basically splits Pennsylvania and goes up to upstate New York. We have this huge human trafficking problem that people are working on that goes kind of hand in hand with that opioid epidemic. So we are still seeing overdoses from heroin, but typically it's heroin laced with something else, because our heroin patients, if they haven't gotten clean and then started using again, are typically pretty good at knowing how much they can use. So if we do see an overdose, it is from heroin laced with something else. But we still have a lot of heroin here. I mean, my patients will do 10 to 20 packs of heroin a day.
Okay, well, this has been a great webinar, and thank you again, Dr. Pinto, for all the information you shared with us today and for all the information you shared during the Q&A as well. And thank you to all of our participants. And I hope that we will see you again at future webinars. And I see there's just one last comment there about xylazine. I don't know if you wanted to.
I typed an answer,
offer it.
I didn't know the answer to that.
Okay. That is something that we are starting to see in our data in Maryland as well, I believe. So thanks again, everyone, and we hope to see you again next time.
Thank you all for listening.